Do you have any effective strategies for improving treatment adherence in younger axial spondyloarthritis patients who feel too well once symptoms maybe partially improve and start skipping things like injections or pills?
Yeah, so something that's helpful, I do realize that sometimes, we have the benefit as physicians of foresight. So we've seen so many of these diseases, and we could see what happens when patients don't take their medicines. For example, a lot of persons who do have axial spondyloarthritis, their diagnosis, that might be the first time they even heard about this disease. And oftentimes they're also the only person that they know of that has this disease. So I think, what's very helpful for me is that taking the time to explain to them just what the natural history of the disease looks like, and, just how this will advance in terms of, worsening quality of life. I know, mobility is something that's so important. So like my young patients, so sometimes just walking them through pictures on Google Images, sometimes just to show them what could potentially happen, right? So, even though, a lot of these diseases don't necessarily lead to death per se, there is increased risk of also infections, right? With ongoing uncontrolled inflammation. The immune system is not functioning at its greatest. So I counsel them on increased risk of infection, as well as you mentioned earlier, increased risk of atherosclerotic cardiovascular disease. So it's sometimes just taking the time to just kind of sit with the patient and just letting them know just how this will evolve over time. And I've seen where it's been helpful where persons, and it takes some time, Rome wasn't built in a day. Sometimes you just have to slow down, just go at the patient's own pace. And sometimes if the disease, comes back with a vengeance or it's just really hard to treat, then that in and of itself might be, the turning point for the patient.
How do you approach shared decision making around tapering biologics in patients with sustained remission, given guideline suggestions that taper may be considered rather than abrupt discontinuation?
Right. So I think a lot of this is also physician patient shared decision making. There's some patients who do not want to come off of their medicines because they remember what life was like before it. And then there are patients who really want to stop their medicines because they don't really want to be on these injections, lifelong. The data does show that if you do taper off the medicines, and a large majority of patients will have recurrence of disease. So again, if there's someone who really wants to get off of their medicine, maybe we could try, spacing out the dose a little bit more. If they're on Humira every week, we could probably take it, after they've been in remission, to every 10 days or then to every 14 days or so. But again, it would really just be dependent on, again, physician patient shared decision making.